last session for this morning is biomarker research and development of tests for progression of latent TB to active disease. The first speaker is Mark Hatherill from the University of Cape Town, and the talk is Diagnostic Markers for Accurate Prediction of Activation of Latent Tuberculosis, Progress and Needs. A lot of needs.
Indeed. Thanks, Daniela. So I'd like to acknowledge at the outset that the data I'm going to be presenting is the work of many other people. I'm presenting on behalf of Tom Scriba, who leads the correlative risk development work at SATFI at the University of Cape Town. So before I show you some data, I think it's important that we calibrate our paradigm. So I'm sure this audience is familiar with the concept of the continuum of TB disease, from quiescent infection to clinical disease, and all of these individuals being latently infected, or indeed infected as determined by IGRA or TST positivity. I want to make the point that in high-burden countries, in TB endemic countries, 50 to 80% of adults are TST or IGRA positive. Where you are sitting now in South Africa, between 70 to 80% of otherwise healthy HIV uninfected adults are TST or IGRA positive. It's also important to remember that 90% of these latently infected people will remain perfectly healthy and will not develop TB disease in their lifetime. So what do we do with this? What are the implications? Well, in a low burden setting, clearly it's important to identify the relatively few individuals who are latently infected with M. tuberculosis so that they can be provided preventive therapy. What about the high burden setting? Is it feasible to target latently infected people with preventive therapy? And I know this is a potentially controversial subject, but if we were to do this in a country such as South Africa, we would need to identify and treat approximately 3/4 of the population in order to prevent a relatively small number of cases. And I would argue, for a host of reasons, that this is neither reasonable or feasible. So in this paradigm, and I'm stressing this is the high burden setting, we need to shift our focus from treatment of latency to provision of preventive therapy for those individuals at highest risk of progression to disease. In other words, not all of these people, but in fact, these people. So I'm going to tell you a little about the discovery and validation of a prognostic correlative risk for TB disease. These data come from a large cohort study of 6,300 adolescents. Some of you might have seen these data before. This study was conducted just down the road near Cape Town. And these 6,300 adolescents were followed for at least 2 years and were sampled sequentially. PAX-gene RNA samples were collected throughout the study. And at the end of the study, as you might expect, the majority of individuals remained perfectly healthy and did not develop disease. And these are the controls. And a small number did, in fact, develop microbiologically confirmed TB disease. So we ended up with a small number of 46 cases, and these cases were matched by age, gender, ethnicity, 1 to 2 to healthy controls. These were then split into a training set and a test set. And when we look at the differential expression of genes, we see that we have more than 2,500 genes that are differentially expressed between these cases and controls. And there's some important issues to bring out here. First is that we have genes that are relatively underexpressed in cases, and we have genes that are relatively overexpressed. But we see this differential expression increasing in intensity as we move from more than 18 months prior to TB disease diagnosis through to time of diagnosis here. And we see this in the training set, and we see this in the validation set, and we also see it, although I'm not going to show any of the data, we see it in a separate cohort of household contacts in the GC6 study. But 2,500 genes is a lot of genes. So we also note, and I don't know how this projects, I think you can see, so we also find that it's possible to differentiate between cases and controls, cases, the progressors in red and controls in green, on the basis of the relationship between pairs of individual genes. So this paired relationship effectively functions like a vote, where a sample might be determined to be a control, or a sample might be determined to be a progressor or a case, depending on the relationship between these two genes. So if we take this approach, there are certain genes that come up repeatedly as being one of these discriminatory pairs. The majority of genes, of course, do not add value. But if we take a computational approach and whittle down the genes that do not add value, we end up with a 16-gene ensemble of 247 transcript pairs that allow us to discriminate between TB cases and controls. So here, largely in red, we see an example of a sample where the majority of pairs or votes are voting that this is a sample from someone who's going to progress to TB disease. And here we see a sample where the majority of votes are that this is a non-progressor or someone who will remain healthy. But of course, RNA-seq is not really a practical tool for high-volume screening for tuberculosis in a high-burden country. So we need to transfer this model to a real-time PCR platform. And we're aided somewhat by the fact that this is a relatively parsimonious model, as such models go. And so the correlate model was transferred to the Biomarker fluidigm system, which allows us to test on a single chip up to 46 duplicate samples. And that gives us a result in 2 days, and with a computational script will then give us a yes, no, or a positive, negative answer as to whether or not an individual is at high risk or low risk for development of TB disease. I want to go back now and remind you about this issue of time. So remember that the genes, and in blue we've got the correlate model genes. These genes are upregulated compared to controls even beyond 600 days prior to diagnosis of TB, which is here. As time passes, they are increasingly upregulated, as are the other gene modules that you'd expect. So here, inflammation and the interferon pathway. And that signal being strongest at the time of disease diagnosis. So the question arises, although this correlate was not developed as a diagnostic as such, is whether in fact this correlate has some potential utility as a triage test for prevalent disease at the time of sampling. And so this model was applied to published microarray data from other studies of diagnostic correlates for tuberculosis. And we see indeed that this correlate model is able to distinguish TB disease from latent infection and from uninfected individuals in South Africa, other African countries, and in patients from the UK. And this is prevalent disease at the time of sampling. But our primary interest was in fact whether the, just to continue on this, so when we drill down then, and these are restricting this analysis to HIV uninfected South African adults, and we compare the 130 prevalent TB cases here and 230 controls, we have a range of specificity ranging between 81 to 100% and sensitivity ranging between 80 to 90%, with an average of 97% specificity and 87% sensitivity for prevalent disease in the setting of a triage test. But as I said, our main interest was in correlate prognostic performance. So if you look here on the left-hand side, and focus, I think, mainly on the red, the orange, and the purple lines, we can see that this correlate is able to distinguish individuals who will develop TB disease within 180, 360, and 540 days prior to diagnosis. Beyond that, performance falls off more or less entirely. If we take then on the right-hand side, we'll just take the example of disease occurring within 1 year of sampling. As with other tests, the sensitivity and specificity is dependent on our vote threshold. In other words, what percentage of those voting transcript pairs vote that this is a case or not. And if we take the 60% vote threshold, we can see that we have 70% sensitivity and 84% specificity for incident disease occurring within 1 year of that sample being taken, which in terms of a diagnostic would not be of particular use. But again, we're talking about a prognostic. So how might we use this test? So the question then arises whether the correlate could be used to target preventive therapy. And here we've seen that the key issue is the speed and extent of coverage of any such preventive therapy regimen. So, as we mentioned before, the correlate performance is time sensitive. So in fact here you can see very nicely that it decays exponentially over a period of approximately 21 months with hazard ratio for TB disease beginning here at about 15, decaying to 1 at 21, 22 months, which suggests that the period during which this correlate might be useful for prognosis is probably up to about 12, maybe 18 months prior to disease occurring. So this is important if we think ahead in terms of utility and rolling out mass campaigns and the time such campaigns would take to achieve complete coverage. So what are the challenges? So clearly there are many at this stage of this work. The first is to develop a stronger proof of concept in HIV uninfected persons. So we have case control data at the moment. We have no data from prospective correlates of unselected individuals. And we need more data from more participants to evaluate this correlate as a potential triage test, but predominantly as a prognostic test for incident TB. I will mention that there is ongoing work evaluating the potential of this correlate as a treatment response marker, because indeed in the small number of patients that we have studied, the correlate signal does decline on treatment to almost to baseline at the end of treatment. And there's some work going on to evaluate the correlate then as a treatment relapse marker. The question being whether individuals who have a positive correlate signal still at the end of treatment are those who will go on to relapse disease. And of course, the majority of work has been conducted in HIV uninfected persons, and we need to conduct similar studies in HIV infected people. The critical issue, of course, is if we're going to use such a test, then is to move testing out of the laboratory and into the community. If we're going to achieve screening at scale, then we would definitely need point-of-care testing, and discussions with various point-of-care developers are ongoing. But point-of-care testing would allow rapid and extensive coverage and allow a screen and treat strategy to be developed, which might couple correlate testing with short-course preventive therapy. And indeed, such a study has been planned. So beginning middle of 2016, the CORTIS trial will evaluate the efficacy of the 3HP preventive therapy for prevention of incident TB disease arising in correlate-positive individuals. And using the same platform and additional study arms, will gain further data to assess the performance of the correlate, both for detection of prevalent and incident TB disease. So I think I will stop there, and hopefully there's some time at the end for further questions. Thank you.
the discussion at the end, and the next speaker is approaching. I was looking for you in the audience, and I didn't see you. And it's Claudia Denkinger from FIND, and the talk is Target Product Profile for a Test for Progression of Latent Tuberculosis Infection. Thanks, Claudia.
Thank you very much for the introduction, and thank you for inviting me to speak here and for you to take the time to come. So you now heard already some very promising development on a test, and this is kind of a little bit after the fact, because this is the thinking around, like, how should a test look like that we would like to have that predicts progression from latent to active TB. And most of you might have heard of the efforts done by a large consortium of people that resulted in this document last year in April around high priority target product profiles for new tuberculosis diagnostics. This was an extensive iterative process with input from many stakeholders. However, these TPPs defined here were all for diagnosis and DST, and obviously there are other needs such as the latent tuberculosis and improving those tests and better getting prediction to active TB. So this in the cascade of the patient certainly comes before they first present with symptoms. So we have gone through parts of a similar process as we did for the TPPs for active TB. So we drafted a TPP at FIND, and we reviewed this with experts. Then we were glad to have like a meeting in May this year, organized by the new diagnostics working group, WHO and FIND, with getting experts together to discuss this TPP, which resulted in a revised document. And this is essentially where we stand at this point. And in the next step, we want to do a survey of a larger group of stakeholders, also leveraging the newly founded WHO LTBI task force, and to finally get to like a consensus document that can be published. But as we are thinking around, like, what should the next generation LTBI tests be? Like, we have to think about, first of all, what we have. And you know all of that. We have the ICRAS, we have skin tests. But what are the issues with those tests? The available data suggests that the majority of the patients who test positive on these tests will never develop tuberculosis. So the predictive value is really, really low. Also, they don't have the capacity to differentiate between recent and remote infection, which is important because most of the recent infection will likely progress. And then, on the other hand, monitoring response or cure with preventive therapy for LTBI, that also is not a feature of the currently available assays. So thinking about what we are looking for in a next generation test, we're looking for a test that has better predictive value, that will tell us who of those many, many patients latently infected with tuberculosis will actually progress. Also, we want to have a test, ideally of cure. So once you have, when do you have received sufficient therapy? Can it predict relapses at the end of therapy? And in addition, like, is the test able to detect re-exposure, so will turn negative and turn positive again after treatment was taken? And those are the aspects that we are looking for in terms of individual patient diagnosis. Other aspects that would like to have is the epidemiology and research goals for such a test. A test would be used for surveillance and thus can obviously help to inform the burden of disease and ideally also identify recent transmission. So looking at that in terms of the spectrum of TB, from like the first exposure, innate, and then acquired immune response, the quiescent infection, which is essentially the pool of latent TB, of that a subset will progress to active TB and then disease. So we are looking for a test that ideally identifies infection that progresses and also ideally differentiates that from the latent infection that never progresses and then detects cure, predicts relapse, useful in re-exposure. So a lot of asks from a test. So I think we need to focus, and what we focused on with target product profile development was this aspect of what I spoke about before. So a test that is better in predicting who will develop active disease from the latent tuberculosis infected pool. As we are talking about test as such, and Mark actually put up a similar concept already, we need to have our definitions straight. So I think we all know what active disease is. We all know what latent disease is, latent infection is, sorry. But there is this whole spectrum in between. Oops, yeah. I called that here subclinical TB disease, and Mark had that on his slides as well. So that's the patients who are essentially in between. They have latent tuberculosis infection. They are on the pathway to getting active TB disease, and they might either not mount a sufficient immune response to actually have symptoms, and that might be more the immunocompromised patients, or they might be very early and have still contained disease, which is mostly the immunocompetent patients, and those will ultimately progress to clinical TB. So those are the patients that are on the pathway here. So having those definitions in mind, what we are looking for is really like these, identifying the patients who will be progressing. So thinking about the test, we need to define who we want to test, and that's patients at risk of latent infection or at risk for progression. And we want to make sure, obviously, that these patients do not have active TB. And what would be the use cases? Differentiating them between high and low burden settings. In high prevalence settings, where we have obviously huge pools of risk of patients at risk for active TB. May that be because of their recent exposure, or may that be because of their underlying immunocompromise. And also the NTB strategy of the WHO obviously aims for elimination of TB, and there we need to target also low and medium prevalence settings, and there the largest pool of active TB stems from patients who are latently infected, oftentimes many years ago. And then we need to think about where we want to test and where we want to give the result to the patient. Do we want that do we want like a test that gives us a result immediately so we can inform the patient, or do we actually need that? Do we need a point of care test, or can we live with a test that has a longer turnaround time and can be done in a reference laboratory? I mean, we are dealing with a disease where no active transmission is happening. This is latent infection on the pathway to getting active disease. So no immediate clinical decision is necessary from that standpoint. Then on the other hand, the patients, they don't have the disease burden. They are not, it's not on their mind that they have something sleeping in them that might actually progress to active disease in a few months from now. And this might be the one chance that we have them in front of us to essentially start them on therapy. And if they could walk off, they might not come back for that therapy. So that's kind of the trade-off in thinking around a point of care test. So this is essentially in the TPP, we always think about what is the characteristic we want and what is kind of the minimal we accept, what is the optimal that we would aim for. So this is a lot of the same what I just talked to you about. So it's the minimal, we really want a test that is better in predicting progression to active disease within the next 2 years. And ideally, that test would also differentiate from active TB, so would be negative in active TB and would ideally also revert to negative with therapy, and that is essentially the optimal here. We are looking to healthcare workers, on the one hand, like thinking a point of care scenario with minimal laboratory training, like really that have the patients in front of them. On the other hand, healthcare workers in a more reference laboratory setting with laboratory training and skills. So in the next step, like thinking about the diagnostic performance, how good is good enough? And we are almost aiming for perfection, but I think in this context, given the current science and also the timeline that we are thinking of for this TPP, which is the next like 3 to 5 years, we have to maybe go with good enough as being the new perfection. And so in terms of diagnostic sensitivity, optimally, we want to go greater than 90%. But what is acceptable on the minimal side? And I'll go through some thinking around that in a second. On the diagnostic specificity side, and I apologize, this is an arrow that shows that specificity here. Also, again, we want to go high, although actually greater than 90% in low prevalence settings is not that high, and what is minimally accepted. And then, as I said, the optimal test would also differentiate this subclinical infection from active TB, and there you also want high specificity. So thinking about the performance characteristics, essentially, how did we come up with these numbers? This is the premise here is taking the risk-benefit profile into consideration. And in that context, sensitivity and specificity are kind of abstract, and we really want to think about positive predictive value and negative and number needed to treat. Why those? Because positive predictive value essentially captures the patient's perspective. Because if the test is positive, how likely am I as a patient to have to be progressing to active disease? And why should I be taking those drugs even though I'm not sick right now? The number to treat is more the public health perspective. So how many people do we really need to treat to essentially get to prevent one case of active TB? So thinking through this in a stepwise process, we came up with some numbers. So first of all, the number needed to treat. So this is the public health perspective. So what do we have currently? So we have the TST and the ICRAS, and this is obviously ICRAS and TSTs all lumped together. This is taking the data from the WHO review that informed the revised latent tuberculosis guidelines. So currently, the number needed to treat that we find acceptable for these tests is between 85 and 250. So with the numbers that I told you for the sensitivity and specificity here, like we get on the minimum side to a number needed to treat of 40. On the optimum side, we would need to treat 13 patients to prevent one case. So this is actually quite good. If you think, the numbers that I showed you are not aiming not that high. It's not like the 98% that we are always aiming for. So we can actually make a lot of difference with a test that might not be perfect. In terms of positive predictive value, so here, again, this is the patient perspective. How likely is a test positive? Does it really mean that I will progress as a patient to active disease? So currently, the numbers are abysmal, right? 2 to 3%. For the TST and ICRAS, they're not really much better between the two. So in our minimum scenario, as I portrayed it to you, we would have slightly higher, double the positive predictive value, and in optimum scenario, we would have 16. And obviously here, it's a matter also of weighing the treatment, weighing the side effects of the treatment, which very much depends on age group, on other comorbidities, and then of the likelihood of the patient. So I think always we have to not think of the test alone. We always have to put it within a risk profile, and both risk profile for active progression as well as risk profile of getting side effects from latent TB therapy. So that's about the performance characteristics. One other performance characteristic that I think was largely ignored prior in terms of the ICRA assays, and we've seen many of you here have dealt with that, a huge issue with reproducibility of interferon gamma assays, and we summarized that in a systematic review that came out, I think, end last year. But if you test patients repeatedly, then you will see that the reproducibility of interferon gamma release assays has actually issues. So we need to aim with those new tests, if we have quantitative outcomes of a test, to make sure that we are able to interpret them with high reproducibility. A test is, we always look to performance characteristics, but I think equally and sometimes even more important are operational characteristics, and that relates more to where we are doing this test. And that gets back to the question that I asked before, do we need to aim for a point of care test? And we argue in this minimal characteristics that no, We can deal with a test in a reference laboratory, and it can can have a lot of impact. And maybe they should first be aiming for a better predictive value. And I think some of the work just presented by Mark is really aiming in that direction, making a lot of progress. And then in a second step, we can look to how can we improve the operational characteristics? How can we get closer to the patient? And this is a very busy slide that I don't expect you to read, but these are just the key operational characteristics that part of TPP exercise if we look at. So the number of steps that an operator needs to perform, how much sample preparation is necessary, like do we allow for like centrifugation, incubation as part of that? What's the time to result? And here for minimal, we said like 2 to 5 days, again, because we do not have a transmissible disease and we do not really have to make an immediate decision, although we will likely have to accept loss to follow-up if we don't do that. Then what does the test need in terms of, what does it need to allow in terms of operating temperature to not fail in the settings that we want to place it in? What are the controls necessary, power requirements, and training obviously is the key aspects. So I won't go into detail here, but this is essentially portraying between the optimal and the minimal the setting where this test is placed. So the point of care where patients in the microscopy center level versus the minimal more in a reference laboratory. And another key aspect is cost. What is acceptable? This obviously needs to consider the performance of the test. And I think, as I said, it needs to consider also the package of the test and treat. What are the rates of success? What are the risk associated with missing a patient and putting a patient on therapy? Also, I think one aspect is we need to consider how often a test is performed. If we implement such a test in high prevalence settings, people will be exposed very frequently. So this would be a repeat test. And is every year enough? Is every 2 years enough? How often should we be doing this? If we think of how quickly patients progress, especially if they have underlying immunocompromise, it should probably be at least every year. And considering that also needs to be part of that business case, volume and cost calculations. Cost effectiveness study, there have been many for ICRAS done, for example. We need to really look at those and standardize them because, I mean, every test will be cost effectiveness if you look at it the right way. So considering all the performance, as I said, repeat testing on all of that. And even more importantly, I think affordability. Like this depends on the country's priority. If you're busy like trying to control your active disease population, then you might not put this as a priority, and therefore your willingness to put in money in this is limited. But I think there might also be an opportunity here because I think many of the countries with low to medium prevalence settings are willing to put forward money for this, and then this can be leveraged also to high burden settings. So this is just a quick run through. And with that, thank you very much, and thank you also to the people who helped with this, the people from the expert group in May, many of you sitting in the room, and Pratibha Sheshadri, who helped me draft this TPP, Samuel Schumacher, who helped with thinking around all of the performance characteristics, and Daniela Cirillo, who always helps at every end.
Thank you, Claudia. And we are now moving to the last speaker of this morning, that is Frank Cobelens, new predictive test for the diagnosis of tuberculosis infection. Don't kill yourself. How should they be evaluated and what evidence is needed for WHO endorsement? Oh, this is hard. It's a great.
Okay, thank you, Daniela. Good morning, everyone. Thank you for the opportunity to be here and to put some thinking into this. This is work in progress. Just now, Claudia already mentioned this task force that has been established, that has already been together in May, last May in Geneva, to think about these things. This is definitely not the sort of final word that has to be said about it. It's more meant as a sort of basis for further discussion. And I want to acknowledge up front a few people. I mean, many people in the room actually have been part of this and have provided comments and been engaged in that discussion. But I want to acknowledge in particular Daniela, Claudia, Alberto Mateli, who is leading the task force, and Sandra Kik at KNCV Tuberculosis Foundation. So I'm going to focus on this target as the target condition on a test that can identify individuals most at risk of progression. Claudia just mentioned that there are many other reasons why you might want to know about latent TB infection, but this is what we are going to talk about, and maybe we should do away for this purpose with the term latent TB infection at all, and I'm going to show you why. So what we need is a new test that is a better predictor of TB than existing tests. And then you might wonder, why is better prediction important? And also, what does better prediction mean? And the last thing is important because it determines how you should evaluate them. Now, this is what you've heard in the last two presentations, but this is just done differently. So on the, here you have the number needed to treat, which is actually 1 over the positive predictive value for those who are not very much into clinical epidemiology. And this is the cumulative TB incidence that you would expect. So you can see that so this is based on the AIGHD data from a number of studies that have looked prospectively at the risk of developing tuberculosis. And you can see that for very low cumulative incidences, you're looking at very high numbers that are needed to treat to prevent one true case of tuberculosis if you use those tests. And just to give you a feel of what we're looking at, so this is the maximum that you can expect in HIV-positive contacts of infectious TB patients, so about 5%, so that's already a sizable NNT, and this is what you can see in HIV-negative contacts of infectious patients and prisoners. So we're actually very much on the left side of this panel, so we really need to test it. It's much more specific, which would translate in a higher PPV and a lower number needed to treat. Now, you've seen this one before. This is from a wonderful review by Hanif Esmail earlier this year. And I use it, just as Claudia just did, to sort of get a bit at grips as what better prediction means. So on this graph here, there is latent TB infection, which is actually meant as unstable latent TB infection, can go up and down, but it remains below the detection threshold. And at some point in time, there is a precipitating factor, some sort of something that precipitates a progression towards disease. And only here you will see symptomatic disease, and here there is something going on which is asymptomatic and perhaps may even be abrogated, but still there is some sort of distinction. Now, the problem that we have is that we do not know what exactly precipitates disease in a latently infected individual. That means that beyond existing risk classification, we cannot predict who will and who will not become diseased. So in that sense, it's a stochastic effect. But that's not to say that we cannot make any predictions at all. Because if you look at this again, that it means that conceptually, such a test can only be one of two things. It can either be a test that predicts that disease cannot happen because there is no persistent infection or no persistent infection anymore, which I call a persistent infection test, or a test that predicts that disease will occur because it has already started. The process has already started, although there is no symptomatic disease yet. And I call that an incipient TB test. And the distinction is important because it has consequences for the evaluation. So if we take this is a graph that shows you by the time in months, it shows you the percentage of people who are free of incident TB. So here at the left upper corner, we have everyone with a positive tuberculin skin test or AIGHD at the time of infection. And with a test for persistent infection, we assume that there is a certain amount of persons who have actually cleared that persistent infection. And then it can be showed by these tests, which the current methods, the tuberculin skin test, cannot. Now, the problem, of course, is that we don't know how high this proportion is, and this is then what the test would need to show. And of course, it may be that it is not just not a neat horizontal line, maybe it goes up over time. And this would be an example of a test that would be highly predictive. The problem, however, is that we generally don't know where in the process we are, where we are on that blue line in terms of time. Is it shortly after infection? Sometimes we know, but very often we don't know, or is it later on? The other thing is that the shape of the curve where it actually ends depends on the progression rate. And of course with HIV we know it's a very high progression rate, but there are also other factors that determine the progression rate that we sometimes don't know of. So here we are to some extent in the dark. And actually here we are also in the dark when there is reinfection. So if re-exposure is frequent, you will have this part will be much less. There will be much fewer people tested who have a cleared or non-persistent infection, whereas if there is very little re-exposure, that will be much higher. Now, the consequence of this is that the positive predictive value for your test, so also the number needed to treat, is population dependent, which makes it very difficult. Now we know this test. We have it actually. This is probably what our current ICRAs do. They do exactly, at least epidemiologically, they behave exactly according to this pattern. So probably the ICRAs are a test for persistent infection. Perhaps not perfect, but that's probably what they do. But so we have that, and we know it doesn't work, which means we probably need the other test. So we need a test of incipient tuberculosis, a test that shows us that there is something going on which in the end will lead to disease. Now, of course, we want to be sort of early in that curve, and Mark Hatherill already pointed to that, because the further away we get, the higher the bacterial load and the higher the necessity to treat with the full course of antibiotics. And if you're early in the curve, you would probably do well enough with a prophylactic course. Now, a test for incipient TB, the nice thing is it doesn't actually matter where on this curve you are, because it will simply predict that disease will occur. So although this test will have a low probability of being positive, so it will have a high number needed to screen. So you need to screen many people to have a positive test, but once positive, that it should have a high probability of disease, so a low number needed to treat, which is largely independent of the population tested. And we should therefore also, for this test, only expect disease over a short period of time and only look in our evaluations for disease over a short period of time. Now, how short should that be? Now, there's actually very little data on that, but there is a very interesting study that is from 1981 from one of the Hong Kong trials. And this is data from 176 patients in the eligibility screening who were screened out, because whereas they had abnormal X-rays, they had 5 consecutive negative cultures. Now, interestingly, these were followed up for a period of 36 months. Out of those, 93, so about half, developed disease over time, over that period of time, of which 69 were culture confirmed. So half to 1/3 of these actually developed TB over this period. Now, if you look at the curve, or if you could construct a curve here, you will see that after about 18 to 24 months, you have almost all who will develop in this patient group, all of those who will develop clinical overt TB have done so after within 18 to 24 months. So that's the 18 months we just heard in Mark's presentation. So I think follow-up for 18 to 24 months would be the thing to go after. By the way, you see we already have the test. This is it. We just do chest X-ray, abnormal test. Currently we say don't treat. We should probably treat. And someone should look into whether the treatment of abnormal chest X-rays without bacteriological confirmation is key to the success of the Chinese program. May actually be, because that's what they do at large scale. This choice has a few consequences for our evaluations. First of all, for targeting preventive treatment, we are not interested in latent TB infection as such, but in predicting disease, which means that WHO endorsement must be ultimately based on prediction of disease. So that's the first part of the title. This is what we should do. It also means that some designs that we have used in the evaluation of IGRA will be non-informative for this question. For example, studies that compare test results with that of IGRA or TST as the reference standard between quotation marks are not useful. Perhaps they're useful in very early stages of test evaluation as sort of candidate selection, but not for WHO endorsement. Similarly, studies that analyze test results along an exposure gradient to mycobacteria are also not relevant here. This is not what we're looking for. So there have been wonderful studies done, and they've learned a lot about taught us a lot about the epidemiology of tuberculosis and latent infection, but are not relevant for these kind of tests. And there is another corollary, and that is this one, and in fact it was already hinted at by Claudia. That is that a new test may identify actually the same absolute number of patients who develop TB disease as the TST or the IGRA will do, but with much higher positive predictive value, so lower number needed to treat. Which means that the comparative studies that we would probably have to do cannot just have effectiveness endpoints. They should also have cost-benefit endpoints, because this is actually a cost-benefit question. And the question, of course, then, and this is something to be answered, is whether this should be required for WHO endorsement. So now let's go into the evaluation. So we call them analytical evaluation, clinical evaluation, and evaluation for health or public health impact. Well, we can have very long discussions as to whether we should call them differently, but just to give you an idea that there are different phases that we should take into account. Analytical evaluation here is evaluation of different subsets of well-characterized samples, usually banked samples. It's actually just to look at accuracy in the very early stages. Clinical evaluation is to evaluate the test in the intended target population in a controlled setting, by which I mean a research setting, with high quality standards, and then compare the results of the new test against a reference standard. And the last one is to evaluate the test under routine conditions for impact on patient-important or health system important, like cost effectiveness outcomes. And in these kind of evaluations, comparisons against a reference standard are not necessary. Of course, all the other things are also important: reproducibility, conversions, reversions, field robustness, and so on. But I'm not going to address them. I'm going to talk about the first few things. So, for analytical evaluation, the key questions, the first two key questions are sort of initial questions, because if the test doesn't stand that scrutiny, then there's probably no reason to go on to the next questions. That is the test positive in patients with active TB at the beginning of therapy and negative in persons who have never been exposed to Mycobacterium tuberculosis? But once that is clear, the real questions for this evaluation stage are: is the test positive in patients who develop active TB over a period of 18 to 24 months? And does the test remain negative, or is the test negative in persons who remain without active TB over the same period? The design would be analysis of well-characterized bank samples. There are various limitations, but I think this phase is primarily meant to select promising candidate assays rather than that it is meant for WHO endorsement. The clinical evaluation step is much more important for that. The key questions there are: first, is the test positive in patients who develop active TB over that period? And is the test negative in persons who remain without active TB over that same period? And here it is important to include various subpopulations of interest. For example, people living with HIV, people with diabetes, malnutrition, and so on, children. And the studies to be done are follow-up studies of persons at high risk of developing TB, not because they should necessarily be at high risk of TB, because otherwise it becomes a very inefficient study. We have basically two options, or we actually have a third. Maybe you can read it still a little bit, but I'm not going into that. The third is case-based designs. We have cohort designs, prospective cohort designs, or nested case controlled studies. Very briefly about them, a cohort design looks like this. So we do a test at the beginning. The test can be negative or positive. Both are followed up, and we look at the incidence of tuberculosis in both over this period of up to 24 months. And we do active ascertainment of incident tuberculosis. There are a couple of requirements. First, cohort attrition needs to be minimal, which will be related to the length of follow-up. So the longer we follow up, the higher the risk of cohort attrition. Of course, TB case ascertainment should be blinded with regard to the test result. The last point actually, so this is something that can go wrong when you copy-paste from your own slides. So this is from an initial slide set where where I compared the requirements for either a persistent test or an incipient TB test. I think reinfection, it shouldn't be awfully high, But a little bit of sort of reasonable amount of reinfection doesn't really much affect the outcomes. It will affect your sensitivity, we can talk about that later, but not to a huge extent. But of course, if there are huge reinfection rates, such as in some of the places here in South Africa, that may be a problem. The problem is one needs a large sample size, which will depend on the expected TB incidence and the length of follow-up. So it's important to identify high-risk study populations for these kind of studies. One possible option would be to take patients who have been treated for TB and follow them up for relapse as a sort of model of a cohort design. And TB ascertainment should be culture confirmed, which means that there will also always be patients in whom that cannot be done for technical, logistical reasons, which will lead to unbiased relative risk. So in that sense, it's good, but it will increase your sample size. It's something that has to be taken into account up front. Nested case control designs, very briefly, they follow, in that you would follow individuals who have been tested, you would follow them passively over a defined period. We call it a passive cohort. And we would have passive ascertainment of incident TB in that cohort, and then we would compare the test status among those who have been identified with TB to a random subset of those who by that time have not been identified with TB. The nice thing is that you could do much larger sample sizes with this because you don't need active follow-up. The problem, there are a couple of problems with that. I won't go into detail. Also here, reinfection does not necessarily need to be very low. One option, and without going into all these sort of epidemiological detail, one option would be not to test everyone at the time of testing, so that is up here, but only store their samples and test them later on if they are part of the case or the control set. Then finally, that should be 3, evaluation of health impact. Now the key questions here are, does the test, when used in routine settings, improve health outcomes? And does the test, when used in routine settings, improve cost effectiveness? Ideally, here the design would be the design should be comparative and would ideally be a randomized trial. Can be an individually randomized trial or a group randomized trial. And this is the design that we are thinking about. So one would randomize persons in the study population to either the old test or the new test. Everyone who is positive would be treated with preventive treatment, and then we would look at the incidence in both groups of TB. So we would calculate an incidence ratio and an incidence difference. Mind you, one has to follow up both those who have been treated and those who have not been treated, so those with a negative test. The other important thing to look at is the incidence and difference for adverse events, because that may be one of the major advantages of having a higher positive predictive value and a lower number needed to treat for patients. Of course, the difference in number needed to treat would be an outcome by itself, and cost effectiveness would be a very important component. So, in conclusion, what we're looking for is a test for incipient TB, so I hope that this term is going to be buzzed and phrased. This requires a different evaluation approach than used for AIGHD thus far. Endorsement should ultimately be based on predictive power of incident TB. That requires follow-up studies. Cohort studies with relatively short follow-up are needed for clinical evaluation. Nested case control studies may be a useful alternative, although there are a number of methodological hurdles. And randomized controlled trials are ideally done to show impact on patient or health system important outcomes. And for such trials, numbers needed to treat adverse events and cost effectiveness are, in addition to TB incidence, important outcomes. Oh, thank you.
Yes, now the floor is open for the discussion. Thank you, Frank. That was very comprehensive. I would also ask the other two speakers to come up because we will have a joint discussion. Madhu?
So this is more of a Madhu Pai from McGill University, more of a comment for both Claudia and Frank. I think it'll be worthwhile to mention in the TPP very clearly whether you will or will not resort to two things that we already know so well from the TST and AIGHD literature. you expect all of that sensitivity, specificity, and the NNTs to come out of a single biomarker test, whatever that biomarker will be? Or do you allow the TPP to take into account the enormous predictive ability of a repeat test, where a conversion we know, both the TST conversion and IGRA conversion are far more predictive than a single test at one point in time? Number two, the second thing we know very well is if you add age, if you add history of contact, if you add HIV status, we already know the predictive ability of the algorithm is much higher than a single biomarker-based test. So somewhere along the line, you need to say whether all of those expected optimal performance will or will not take into account the predictive ability of a repeat test and all the clinical data that we all often have when we look at a patient.
Thank you. My simple answer to the first question would be no. Because you're not interested in because the reason why we look at conversion, because that is with the current paradigm, is because it is recent LTBI. And we know that a risk factor when you have latent TB infection for getting disease is time since infection. Well, if for an incipient TB test, that wouldn't make a difference. It might be that you take risk stratification into account for reasons of efficiency for testing, because you're not going to test the entire world. I mean, you are going to test those who are at highest risk of actually progressing to disease. That is, for me, that is for me actually also the answer to the second question. So the risk stratification would, to me, not be relevant within the TPP, but it is about how and when you use the test.
I concur with that. I think the first aspect is already integrated as in the TPP, and the second aspect is about implementation of the test. And absolutely, their risk stratification needs to happen. Yeah.
CC Leung from Hong Kong. I think from our clinical experience, if you look at those smear negative and Chest-X positive TB, and one of the clinical way to detect, I think, the development of active disease is compare the change in the Chest-X ray within 6 months. I think for the biomarkers, I think the individual variation in the biomarker may be more valuable in predicting the development of the disease as compared to a cross-sectional analysis, because there could be large variation in between individuals. But within an individual, change in a certain biomarker could be predictive. And that is probably, I think, in the initial design, it could be valuable to save serial specimen, I think, in the same individual, in case there could be certain biomarker whose change will add to a baseline cross-sectional analysis. Because we are looking at something very sensitive and something very specific, we need to look at whether there are possibilities that a serial testing could offer something additional on a single time point testing. We are not looking at the conversion as such. I think there's a separate issue. But from our keen experience in looking at the Chest-X ray progression, you look at the baseline Chest-X ray, sometimes you cannot tell. But you look at it after 3 to 6 months, but then you have some idea whether active disease is going on.
So I would agree entirely. And certainly, let's call it conversion and reversion of these biomarker tests is going to be very, very important to evaluate. We've seen it with IGRAs, and we'll probably see it with new biomarkers. Yeah.
Okay. I do have,
I suppose the answer is I don't know, but I think this is probably, we suspect mostly the host immune response and probably host genotype, but the real answer is we don't know.
Philip.
Thank you all for the presentation. I think that is very, very interesting and enlightening for people who are not too much into latent TB testing still today. So I'm Philippe Jacquin with Cefiet. My question is really that, you've talked a little bit about cost effectiveness, and Frank, in your latest slides, I think you're comparing the existing test, which I understand as being like the IGRA test to the new test that would be doing better, and how we can look at the cost effectiveness of those. I think it would be also very interesting to compare what is the difference between doing nothing and doing those tests, because this is the situation we have today. Because we need to consider that actually today there is not. Okay, so actually there is no today not enough money, if we look at that, and being very practical, to already test people with active TB. So the question is also kind of to the group here, as a new diagnostic working group, is what is the horizon that we see for us to potentially put on the market a latent TB test that will require significant money to be giving some of what one day I believe is going to be useful, when today we don't even have enough to make sure that people who are having active TB get tested.
Maybe if I can answer the first question, I think it's a very good point. I think the reason to include a control group that has the old test, whether that be tuberculosis skin test or other, is especially in settings where that's already being done, because you have to compare to the standard of care. But in the analysis, and especially in the cost effectiveness analysis, you would have to include a base case in which you do nothing. So you have to make those observations as well. I would absolutely agree. And the second question clearly is for the entire group.
So following to Frank's model, what we're proposing here is really detecting preclinical TB.
Absolutely.
As opposed to predict TB. So
well, I think it's a matter of how you put it. I think you put it as prognostic, and I said, well, I mean, I'm a simple guy, so I thought, well, just let's think binary, and then we have two options.
But yeah. I think it's important to distinguish also this idea of preclinical TB, because from prevalence surveys, we know that some of these people actually are culture positive. So they might have actually quite a high burden of bacteria. Question being, do we need then to treat these people with multiple drugs as opposed to only with isoniazid, for instance? I don't know what your comment.
So I think that's a really important question. And certainly from the way we look at the data, I would agree. I think what we're seeing is incipient stroke subclinical disease from way out 12 to 18 months before diagnosis, at the time people become sick. Of course, again, I agree that there are people who are not sick who are culture positive. And the question is then whether, I suppose it comes down to how we would use such a test. And if we would use such a test, for example, as a triage test to say, okay, this is positive, we will now collect sputum, and if it's positive, we'll give you full treatment. And if it's not, if sputum is negative, now you go on to preventive therapy. Depending on what regimen we would choose, we might in fact cure many of those individuals with this, let's call it incipient disease for want of a better term, by a preventive therapy regimen.
Oh yeah, I mean, so what's happening in practice is that with any program for preventive treatment, you first need to exclude active tuberculosis. And the question is, how do you do that? Do you want to do culture or smear or expert? And that depends a bit on the program. I think now that we are, I mean, if we would be able to have a test like that, you may want to have something like gene expert negative result or something like that, just to make sure that you're not mistreating patients. But I think it's more a matter of how we would organize it than whether it should be done.
And just to follow on that, I think it's really important that we get our definitions right here, and that we agree as a community on what that definition should be. So subclinical disease do we say still subclinical disease if we're microbiologically positive? In the expert group meeting in May, like we said, no, like those patients would be actually negative on all existing microbiological tests. So like maybe we need to actually divide that subclinical disease in more subgroups, but agree on the definition so that we can have informed discussion here. And I think there are a lot of questions that will open up with these new tests. Like, is it okay to treat that patient with isoniazid only, or do you need to actually have like maybe a short course of triple therapy? Or So I mean, it's an exciting field for that reason, and I think to inform the discussion, the definitions need to be clear.
I think beyond the development of a new test and the correction of definitions, I think there's also the question of quality management of whatever test you devise. So I've heard a number of points made about the instability of testing. Can you speak up, please? Sure. I've heard a number of points made about instability of testing, but we published a paper this year that shows that test-to-test concordance, meaning negative to negative, positive to positive, in more than 40,000 tests, using T-spot specifically, was 98.9%. And that's a huge, that's a huge difference to other published information. So a lot of that is related to quality management of the assays. And the reason it's not 100% is that there is 0.8% of subjects on a year-to-year basis are converting from negative to positive. So I do think that the quality of the data reflects the quality frequently of the conduct of the assay. And I do think whether it's a new test or an old test, it's very important to spend a lot of time ensuring that it's well managed.
Agree, yeah, point taken, absolutely.
Megan, did you have a comment?
Megan, do you have a question? Megan, do you have a question?
No? Okay.
Then if there are no more questions, I leave the word to my co-chair, Bill. Close the session.
Great. First, I'd like to thank our speakers for that final session. Before everyone runs off, just while people are wandering out, just a few quick announcements. First, I want to thank you for participating. I want to thank our sponsors, QIAGEN and BD, for making this possible. I want to thank my co-chair. Those of you who don't know Alessandra Varga, she's the one who organized the meeting, and I especially think we owe a round of thanks to Alessandra. Just a note that all of the presentations that you saw today should be available on the new Diagnostics Working Group website. So if you want to see the presentations again and have access to them, please look for them there. And thank you again for your attention and participating this morning.
No. Alessandra is in